Okay, students. So this session is on proximal femur fracture, and we will discuss why we need to talk about proximal femur fracture different than adult proximal femur fracture. There are few peculiarities of this fracture. A, this is a high energy injuries, and B, this is quite rare. Even among pediatrics fracture, this is less than 1% of the fracture. The vascularity of the femoral neck and head is very different than adults. There are two growing areas, one epiphysis, one apophysis of the great trochanter, which we need to be careful. And the treatment options are different because in pediatric age group, you can immobilize these children and keep them non-weight bearing and apply spica. So we have different options available. And the pathological fractures are quite different than adult mainly osteoporosis fracture, but in children's we have few pathology you have to look for, especially aneurysmal bone cyst and simple bone cyst, and few metabolic bone diseases like rickets, and quite often a disused osteopenia like in cerebral palsy or polio child, and few other rare condition you need to be careful when you're talking about hip fractures. So what are the other peculiarity? The two main peculiarity you need to know for the exam is the vascularity and the growing pattern of the proximal femur fractures. So let's discuss this a bit more in details. First, about the growth of the proximal femur fracture. We know that the proximal femur epiphysis or femoral head epiphysis appear at 4 months, and the trochanter appear at about 4 years. And before 4 months, it's all cartilaginous. That's why you need ultrasound to detect DDH in very young people before 4 months of age. And both these contribute to growth of the proximal femur. Although trochanter is an apophysis, but it does contribute, other than the apophyseal growth, it contributes to the neck growth. So if the trochanter is arrested, then you can get coxa valga. If it is overgrowing, you can get coxa vera, and it is overgrowth can cause impingement problem also. So you need to careful about both these growing area of apophysis and apophysis in proximal femur. And any abnormality of one can cause a problem with the proximal femur, and that's what you need to be careful. The second important factor, which is commonly asked in the exam, is about the vascularity. And you should know that the proximal femur or femoral head vascularity changes during the childhood. So it's different when you are born. It's different from a 3 to 4 year age to about 10, 12 year of age. And then it is different once the physis is fused. So let's go a little bit detail about this. So when we are born, there is no physis. All this is cartilaginous. So the blood vessels are actually just uh, crossing without any resistance of the physis here. So initially, first few months or first few years, the blood supply is not too bad, but then this growth plate or the epiphyseal plate is become resistant to pass these blood vessels. So the only blood vessel which remain supplying is something which is going outside the growth plate. And this is one of these vessels, which is a branch of medial circumflex artery on the posterior side, and superior and posterior, and that's why it's called posterior superior branch, which is the main common artery remain during most of the childhood. So this is blocked here, both from anterior and posterior. So and this also become less significant, and the ligamentous teres become less significant. So only blood supply is from this posterior superior branch. So quite long period of childhood is a quite precarious blood supply because there is only one blood supply. And later on, when this physis is completely fused, then again the blood supply can transmit from neck to the head, and it becomes slightly better. It is never a good blood supply of femoral head, and that's why it's a difficult fracture to deal. But there is a trimodal pattern during childhood. You should remember that. Then come why don't we treat them like an adult, an intracapsular and extracapsular fracture? Why should we have a different classification? And that is because of this physis we have, because the fracture which goes through the physis are quite different than intracapsular other fractures. So we divide them: one, going through the physis; two, the classical mid-cervical fracture; and then there's a basal cervicotrochanteric fracture; and then the fourth variety going through the intertrochanteric area or slightly subtrochanteric area. So most of the proximal femur fracture between greater and lesser trochanter are considered as type 4. And this is a Delbet classification, which was popularized by Colonna, and this is what you're supposed to know in the exam: 1, 2, 3, 4, separation, mid-cervical, cervicotrochanteric, and intertrochanteric. So how do we manage pediatric hip fractures? We manage same like anyone: history, physical examination, investigation, and treatment. I will not go into history, physical examination, because they are very similar to any painful hip, and the investigation normally requires just an X-ray. Very rarely you may require MRI or CT scan. So we will discuss mainly on the treatment portion of it. You may